Thank you for that, and thank you to the organizers for hosting this session. I have nothing to disclose. But I do want to thank our study participants for making this possible. So I'm going to share findings from an ongoing mixed methods study with people who inject drugs in New York City. But before I discuss our study, I want to briefly highlight some trends in drug overdose mortality in the United States in a slide that is very similar to the one you just saw. But for the sake of time, I'm just going to highlight the gray line, which represents deaths involving synthetic opioids as a category, which is largely, almost entirely fentanyl. So in 2022, over 111,000 people died of drug overdose, with nearly 70% of those deaths involving fentanyl. And now I want to talk about New York City, which is where the study took place. So as you can see, trends in drug overdose mortality in New York City have followed a similar pattern to national trends, with increases after the introduction of fentanyl around 2014, and again at the start of the pandemic. But I really want to focus on the pandemic period, which is when drug overdose deaths increased by 102%, and those were largely driven by fentanyl. As of 2022, fentanyl was involved in 81% of all overdose deaths in New York City, far surpassing any other drug. And methadone, which is sort of the other focus of my talk, was involved in 12% of deaths, and that has remained stable over time. So decades of research, I probably don't need to go into this too much with this crowd, but decades of research on methadone has shown that it's associated with decreased risk of overdose mortality, HIV, and hepatitis C transmission, among other positive outcomes. Nevertheless, in the US, only about 25% of people who are opioid dependent are actually engaged in either methadone or buprenorphine treatment. Methadone in the States is very highly regulated. It is only available at specialized treatment programs that are licensed to dispense the medication. And these programs are governed by pretty strict federal and state regulations, many of which are barriers to treatment, including requiring that a person have a 1-year history of opioid addiction before being able to initiate methadone treatment, and limiting the number of take-home doses that a person can receive. But since the start of the COVID-19 pandemic, some of these regulations have been relaxed, particularly regarding increasing number of take-home doses, as well as the removal of that time frame for being able to initiate treatment. As of this year, those changes actually became permanent. So this mixed method study sought to explore methadone maintenance treatment use among people who are using fentanyl in New York City. I just want to highlight a couple of points on this slide. First, our quantitative sample included 462 people who inject drugs, and the qualitative sample was a subset of that 462, and that included 54 people. We conducted urine toxicology screenings to examine possible unknown drug use. Because the supply is sort of so unstable, we really wanted to understand what people are actually using, and we provide those results to people. Lastly, in the qualitative analysis, we examined themes across the entire sample, but we also stratified quotes to examine themes by methadone program participation, as well as urine toxicology results for methadone. Just want to highlight a couple of points on this slide. The majority of our sample was using drugs daily. 55% of the sample was in a methadone program at the time of their interview. 62% had ever overdosed, and a quarter had overdosed within the last 6 months. So our urine toxicology results provide an idea of drug use over the past 2 or so days. I just want to highlight some of the most commonly used substances among our participants. Fentanyl was used by 86% of participants. This was followed by cocaine at 78%, methadone at 76%, and heroin at 46%. And xylazine, which is a central nervous system depressant that's used to sedate horses and other large animals, and it's being mixed into fentanyl and heroin to sort of extend the effects of it, was detected in 40% of people in the study. But I do want to note about xylazine, we didn't start xylazine testing until 2023, so the denominator for that 40% is 153 people, but that actually has remained pretty stable over time. And then in terms of polysubstance use, I just want to highlight 70% of our participants tested positive for both methadone and fentanyl. And 90% of the people that were in methadone, 97% in methadone treatment tested positive for methadone, and about half, 49% of people who were not enrolled in methadone tested positive for it. So now I just want to highlight our qualitative themes. So in qualitative interviews, we found as you might have guessed, given the urine tox results, that non-prescription use of methadone or methadone that was purchased from a friend or from someone or received from a friend was really done by both people that were and were not in treatment. So this first quote comes from a construction worker who was in methadone treatment at the time of his interview. So we first asked him, have you ever bought methadone from anyone outside of the program? And he says, if I had to go to work, or sometimes it's real early, 5 or 6 in the morning, they don't open, I know the job's gonna go longer until they close, I'll buy it because I can't make it to the program, or if I miss it by mistake and I have money to buy it. Some participants had significant health issues that occasionally prevented them from making this trip to the clinic every day, which is what a lot of the programs require. So to prepare for this eventuality, several participants reported that they'll buy methadone to have around just in case they needed it, as this person explains. She said, I don't buy it to use double, I just buy it to have on hand in case I can't get up and don't want to go to the program because I have herniated discs and metal balls and screws in my leg. So among people who were not enrolled in a methadone program, reasons for non-prescription methadone use was frequently overlapping with the reasons that methadone program participants reported. So for example, many participants who were not in a program also reported buying methadone to keep on hand to avoid withdrawal in the event that they were unable to buy heroin or fentanyl, as this person describes. I actually get methadone to keep at my house just in case I can't afford it, can't get it, somebody's not around. I keep it so I don't get sick. I only use it for emergencies and I buy 150 milligrams. For other people, buying methadone can help stabilize them so that they can travel, go see family. So in this excerpt, a participant who has never been on a methadone program was very swearing up and down that he would never be on a methadone program, describes a very specific occasion in which he would actually buy methadone. And here he refers to a 20 milligram dose. He says, the 20 gonna last me all day. I don't wanna get high. Say if I go out of the country, I wanna go down south and see people, I take methadone. As I mentioned previously, overdose was common among our participants and concerns about the drug supply and overdose were commonly reported. This first quote is from a participant who was not enrolled in a methadone program during the early phase of the pandemic, though she is now. In this quote, she describes why she would buy methadone from friends during this time. She says, well, when COVID-19 hit and all that, it was hectic, so I didn't really want to go out there and try to get something. Too much was happening already. I wasn't trying to get just anything and catch an OD. I got meth from people that I know go to the program. I wasn't in the program at the time. I would buy a couple bottles so it could last me. I'd break up the dosage like that. Similar concerns about the unregulated drug supply were reported by other participants after the COVID lockdown period, as a participant describes here. Right now, I prefer to have methadone than heroin for a lot of reasons. It lasts me longer in my body, and I know what I'm taking. So many participants reported using methadone as a way to manage their drug use, particularly to ensure that they didn't experience withdrawal, as I mentioned. For some participants in methadone programs, their methadone dose was not able to stave off withdrawal as it once did when they were using heroin without fentanyl. In this quote, a participant who has been in a methadone program for over a year explains his current experiences with withdrawal. He says, if I'm sick and I take a dose of methadone, which is 170 milligrams, after 2 or 3 hours, I start not feeling good. Methadone used to even, you could do 100 bags of heroin, of real heroin, and then you could drink your meth and you're okay for 24 hours. But fentanyl, the meth only lasts for a couple of hours, and then I'm feeling ill again. And it's scary because it was always like, okay, I'll drink my meth and I'll be okay. Now there's a timeline. I'm like, okay, I drink my meth, I have a couple of hours, let me see where I can get some money so I don't feel sick. A handful of participants discussed the inability of methadone to block the effects of fentanyl, even on high doses of methadone. So in the following excerpt, a participant who had been on methadone for over 20 years discusses why fentanyl has made managing his opioid use more challenging as compared to when he was just using heroin. He says, I'm on methadone, the highest milligrams. I'm at 360 milligrams. It's a little embarrassing, and I shoot heroin, which really isn't heroin, it's fentanyl. The reason I brought up why I'm on 360 milligrams of methadone is that the methadone stops the euphoric effect of heroin. However, now the methadone doesn't stop fentanyl at all. So in the last couple of years, I've gotten a fetty habit. A handful of participants talked about the intense withdrawal effects they experienced using fentanyl that was contaminated with xylazine. In this quote, a participant who had been in methadone treatment for 34 years describes the intense withdrawal effects that he has experienced due to xylazine and why he believes xylazine is increasing interest in methadone, even though it doesn't treat xylazine withdrawal. He says the problem with tranq dope, and tranq is sort of the street term for xylazine, the problem with tranq dope is you don't have the same withdrawal as regular heroin. That pain, the reason why a lot of people go to methadone and everything, it's severe. It's like having flu to the 10th power, and it's really bad. If you get a bad habit, add this to it. It's a different habit. It hits a different receptor than heroin. So when you have a tranq habit, if you get a regular bag of dope or regular fentanyl, none of them will get you straight because you have a heroin habit and a tranq habit, which are two separate things, even though they come in the same bag. So just to wrap up, in this study, we found a large proportion of participants who were using both fentanyl and fentanyl and methadone. Some participants experienced withdrawal within hours after taking methadone, even for people on high doses of methadone. Some participants reported that this led to more consistent methadone use or fentanyl use in order to avoid withdrawal. And then further complicating withdrawal experiences are the continued changes that we're seeing in the unregulated supply, some of which create new withdrawal effects that can't be treated by opioid agonist treatments. For some people, the increased toxicity and unpredictability of the drug supply has led them to reduce their use of street drugs and increase their use of methadone, including enrolling in a methadone program and/or buying it off the street or from friends. We acknowledge that this latter is diversion of regulated methadone. But like our plenary speakers mentioned yesterday, we need to rethink about diversion. In our interviews, participants both in methadone programs and those that were not were purchasing diverted methadone to manage their drug use, often to reduce their exposure to the toxic drug supply and thus reduce their risk of overdose. And this is plain and simply harm reduction. And to reiterate another point that Thomas Kerr mentioned yesterday in the plenary, diversion really points to an unmet need. So our results highlight some of the barriers in access to methadone treatment in the US. There were participants in the study who were enrolled in methadone who reported needing to buy diverted methadone because of their inability to get to their programs due to family obligations, physical challenges, or work. And while daily dosing requirements for methadone patients in the US actually have been relaxed, the use of expanded dosing is at the discretion of clinic staff. A recent study by my colleague Ashley Jordan found that while weekly to monthly dosing that is allowing people to take home 14 to 28 doses per month significantly increased during the early part of the pandemic in New York State, it has gradually returned to more restrictive daily dosing. So together, our findings suggest that we really need to increase access to methadone, but we also need to acknowledge that methadone is not working for everyone, and we need to expand our options for people, including safer supply approaches, as our friends in Canada have done to respond to this crisis.
Courtney?
Yes?
We're really at the end.
Okay, I'm done. This is our team. I just want to thank everyone, and then happy to take questions.
Great. Questions?
Hello.
Hello.
Sorry, you mentioned methadone not working for everyone and needing more viable alternatives. And I was just wondering if any of your participants had a beneficial experience with buprenorphine compared to methadone.
Yeah, so we had less than 10%. I didn't even present on the buprenorphine experiences because I'm writing a paper on this right now, and I originally had the BUP section in the paper, and it was just too long, but also less than 10% of our participants were on buprenorphine at the time of their interview. Many of them had, I can't remember the number off the top of my head, but I could get it to you. Many of them had been on buprenorphine at one time or another, but overwhelmingly, people were not at all interested. They were really concerned about precipitated withdrawal and just sort of the transition, and I think understanding from other people that BUP is not, does not manage fentanyl well, people with a fentanyl habit.
Thank you.
Yeah.
All right, we'll rock on. Thanks, Courtney. Super.